So, what really is future proofing a professional PT career? We're hoping you think of it like this. You should be skating towards where the puck is likely going and not where it is right now or where it was last season. So, having a strategy and plan for your professional career and for the role you play, or maybe you want to play in the business of healthcare, should be a non negotiable. Look beyond the clinic and the day to day stressors and frustrations most clinicians feel because there are signs and signals out there. The signs can come from many places, but here are two places to start. There's so much information publicly available, but you do need to know where to look. First, what are influential stakeholders with decision-making authorities saying, like policymakers? What are their advisors saying? What have they done in the past, maybe, and what lessons might they have learned that they hope to apply? And then what are investors and investment firms purchasing? Those can give you some ideas of where the hockey puck is going to be headed next. And then future proofing and the profession of PT itself. The profession's still relatively young, right? And for the last couple of decades, we've been pushing for autonomy. And autonomy from what? Well, from the requirement that another provider type must write a prescription for us to provide care to someone who's clinically indicated for PT. That's a physician or even a physician extender. So like an advanced practice provider, which would be a nurse practitioner or a physician assistant or clinical nurse specialist. The direct access work moved us forward in many ways, but it's also unintentionally perhaps taken our eyes off other systemic problems that directly impact us. So what is that exactly? Well, the fee-for-service third-party payment structure. It has been a disincentive for physicians and APPs to engage patients sufficiently in the value of PT and help get them actually through the door and into a PT clinic. The fee-for-service structure also incentivizes our profession to prioritize volume or units of care and the length of an episode over individual patient needs. And this has impacted our professional autonomy, but it also impacts how other providers and payers view physical therapy. Therapy can be time-consuming and seen as a big commitment, and that perception goes through consumers, through other provider types, and has become sort of like a norm about how we're perceived as a profession. It's often like detracts payers and even other providers from sometimes seeing the necessity, the patient-specific benefits. Alex and I prepared episode 12 of the podcast, and today we're diving into a crucial topic that affects every physical therapist's future: remote therapeutic monitoring and how it intersects with the Center for Medicare and Medicaid Innovation Strategy. In this episode, you're going to learn how the healthcare landscape is rapidly evolving and why understanding RTM isn't just about the billing codes. It's about really positioning yourself at the forefront of healthcare delivery. Alex and I will break down the latest developments in healthcare technology, payment models, and what it means for your practice. You don't want to miss Alex's brilliant analogy either of the train model for hybrid care delivery, which perfectly illustrates how digital health and in-person care can work together. We'll also share some insights from the CMS Innovation Center, some of what their leadership has been saying publicly over the last couple of weeks about their vision for healthcare delivery and payment reform. And then we have a resource database, as you know, for our newsletter subscribers. And it includes the CMS Innovation Center strategy document that we had discussed in this episode and detailed guides on implementing RTM effectively. If you haven't subscribed yet, make sure to head over to Future Proof PT and make sure you get these resources. They're updated every time we put out an episode. And then everyone who's a subscriber can then link to those resources and their updates So, with that, let's launch into episode 12. Hi, welcome to episode 12 of the Future Proof PT podcast. I'm back here with my awesome co host, Alex Bendersky. It's been a few weeks. We've been traveling a ton. It's a super busy season for both of us. So, we're glad to be back in the studio after a few weeks off and excited about some fun topics to chat about today. So, we're going to cover, well, we're going to start off with at least some more conversation about RTM. And then we're also going to talk a bit and intertwine with this a bit about the Center for Medicare and Medicaid Innovations strategy for the next couple of years, which not surprisingly includes a lot of planning around data integration and, RTM technology and any technology that helps meet patients where they are and helps engage patients is part of that discussion. So why don't we dive in? Let's talk RTM. And Alex, let me give you the starting point here. What do you think? What do you want to talk about with RTM today?
Let's do it, Dana. Reporting from sunny Denver, Colorado.
Woohoo.
Woohoo, 55 and sunny. But I think, RTM has been really at this point a well thought out process that still cannot find a true market fit. So there's a lot of companies that are doing a really good job creating these extensions to a traditional service, but the market still has not fully embraced and accepted it. And we still are yet to really well define these extension services. So we continue to label these processes under the billing codes that they go under, which is RTM. Right? Going into the RTM as a process, you really look into three variables that have to be well defined. The structure of the delivery has to be remote. It has to be therapeutic, so it has to be something of clinical value, so natural extension of musculoskeletal care. And it has to be measurable. It has to be something that measures the different data points, different attractions, right? So I think it's definitely a worthwhile venture to discuss RTM from the state where it is, and also discuss RTM from, I think, the way it should really be executed, which is a creation of true hybrid services to create a stopgap measures between the episodic care provision. So go ahead, tell us what you have.
So coming from I'm looking at things from the policy lens and trying to read some tea leaves. I'd say, well, RTM is still pretty new and it's being used very variably, and it has a whole lot of potential if used well, to align with the goals of this administration's CMS and CMMI. And a lot of that revolves around, accessing what patients need at the right time, in the right place, and communicating, engaging with them more effectively. I think interestingly, as this administration is talking more about what their goals and priorities are, they're talking a lot about developing consumer-facing apps that are trying to catch healthcare up with what we're doing in another industry. So I heard a parallel made by a prominent policymaker at a conference a couple of weeks ago, and he said, I want healthcare to be like this when you're trying to compare and make decisions and feel empowered and have it be really simple. I need to take an Uber. So I look on Uber, look at their price. 10 seconds later, I look at Lyft, I look at their price, and I just click and make a decision between the two because I have the information I need to make that decision. He wants to use technology to bring these kinds of more simple decision making to healthcare decisions and use that as more of the framework to get better outcomes in combination with value-based care models. And I think there's a lot that therapists should be taking away from this. Whether or not therapists are paying attention, I don't have a pulse on, but I would, really encourage therapists. I'm going to show you this website. Okay. If that's okay, you don't mind me, all of us taking a look at this now.
For sure.
So what I'm going to show you guys is the CMS Innovation Center strategy to make America healthy again. This was scribed by Abe Sutton, who's the Center for Medicare and Medicaid Innovations Deputy Administrator for CMS. And so what his job is to take the models that are out and about and being used now, which are a much larger scope of the Medicare population than they ever were. What he's articulated is we need to get dollars that are spent in those Medicare and Medicare Advantage plans. We need those dollars to be in downside risk with providers. So essentially, what he's saying is, look, our goal, and we will use mandatory participation as much as we need to achieve these goals. Our goal is to get Medicare beneficiaries into care models where the provider who's accountable for their care is taking significant downside risk. Downside risk means a provider is responsible for outcomes. What we know from the last 10, 15 years is the more the provider themselves is responsible for outcomes, the more they change how they deliver care. A lot of times payment mechanisms look different, so they have more flexibility. So his goals are promote evidence-based prevention, empower people to achieve their health goals, and driving choice and competition for people. And I think where this relates to what we're talking about with RTM and with apps for managing patients, helping patients manage their own care, evidence-based prevention. This is great for therapists to know. He's defining it broadly. So promote evidence-based prevention doesn't just mean smoking cessation. It doesn't just mean colonoscopy screenings. It also means, and especially for the Medicare population, it means chronic disease management so that the patients themselves better engage in the care of their chronic conditions. That's diabetes and heart failure and osteoarthritis and Parkinson's and yada, 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 right? And that by helping engage patients, by incentivizing providers to provide care differently, by paying differently,
Yeah.
we can achieve these tertiary prevention goals, which are what's costing the most money. 93% of the spending for Medicare is in chronic conditions. Knowing that as therapists and knowing that so much of what we do right now is addressing this chronic care management, maybe, a lot of times it's through episodes, but we can argue that point that there's a lot more therapists can and should be doing.
Yeah.
What do you think about this so far,
Yeah, so there's a couple
Alex?
of things to dig into here, and
Mm-hmm.
one is that chronic disease management, I think, is a well used term. But what are the levers, and what are some of the ways that a general clinical community is being brought to essentially this oracle of disease management, right? So what are we doing to prepare the structure of care delivery, and what are we doing to prepare the reimbursement cycle for the care delivery? One can argue that any time a human, an adult experiences a musculoskeletal problem, it really isn't a chronic problem unless it comes from a single episode of trauma. So most of the things we see in a traditional level, right? These are episodic encounters that tend to flare up once or twice a year and tend to need ongoing care through the life of the individual, with episodic escalations of care, either through procedural care or through in-person care in physical therapy. But what are some of the strategies, and what are some of the ways of defining this prevention, and what are some of the ways to really differentiate the roadmap, the care recovery roadmap for a clinician, so that they can really start to bifurcate the way we deliver care from someone who just really needs this one episode of care, which is few, and someone who needs an ongoing support system for this chronic disease management. And I think that's where we can actually go back into the point one of RTM systems, right? That the digital support and a digital ecosystem, which is really primed to offer this asynchronous, around the clock support and really reassurance, but also advice and access to evidence-based practices, that is, again, well defined. Now it's there, the digital ecosystem is there, but it's being poorly utilized because I think there's still this gap between in-person delivery, which really it should be used to promote these digital solutions, and then these digital resources and digital technologies, which I think are becoming omnipresent, but are only becoming omnipresent in their way of being evaluated, but not really being accessed with still low levels of engagement. So I think the optimal model, the true optimal model, is a true way of using in-person care to actually promote, educate, and deliver digital processes, and then using these digital processes as a way to gain access and accessibility to in-person care when it is needed. And so in a well-defined and well-structured model, then you will see these episodes of in-person encounters followed by digital ecosystem, which will support the individual for in the time when they're not receiving care. Uh, and that's for the rest of their life, right? Like that, like essentially, I always use a train model. So anytime you get on the train, that you are in a digital ecosystem, and anytime you have to get off the train into a station, whether it's a physical therapy station where you're receiving in-person care, whether it's a procedural station where you have to receive a clinical procedure, or any other station, these are the stations that can be predicted and well positioned based on data that emanates from that individual who's receiving care. So then we go to the third point that I think we'll discuss in the future, which is this uh, data points, clinical data points that can help us predict and deliver more efficient care. So again, we go into the middle person, the middle vehicle of delivery, which is the digital ecosystem. Digital ecosystem can be used to deliver structured data collection, both outcome measures, but also human-centric data, biometric data, any point of data that revolves around that individual that is in the need of receiving care to better anticipate the escalation of care, to better anticipate the recovery methods, and to, I think, to objectify the care delivery, but also the recovery cycles. So what'd you think of that?
Oh, there's so much good stuff to dig into, and I totally agree. And the way, not surprisingly, you're thinking is, I think, as we're just listening to Abe Sutton and Dr. Oz and others in the administration talking about this over the last couple of weeks, it's very aligned with what their goals are. And for everybody to keep in mind, the Innovation Center doesn't have to go through the traditional ways that we change regulations, right? They're not subject to what they call the annual rulemaking cycle. So think physician fee schedule. That's how we update Medicare rates for providers. It doesn't, the Innovation Center doesn't have to go through that process. They can create models, they can test models, they can change models whenever they want to, essentially. There are some little bit guardrails here and there. This administration is articulating wanting to create them, make them tough enough to make sure they get the results, which are savings, as they're articulating, and then give it the time that they make for the model, and then expand upon or make permanent whatever works. They intend to make everything that they test or plan for it to all work, meaning it's going to be challenging enough, and they probably have to mandate participation so that you don't get participants only joining that are very confident or have arbitrage opportunities. Generally, that's what that means, right?
Yeah.
So, but to dig into how this specific to something like RTM, and what I think is so really important to call out for therapists, the data, a lot of the data is already available. A lot of the challenges that we have with the data, or as we've talked about in the last episode, the quality of the data that's found in something like a therapy EMR really needs to be up leveled. Because as you know, like I said, the Innovation Center can just decide to require APIs so that they can pull directly out of all EMR data, right? They want to be able to pull things out as soon as you hit, like, claim submitted, they want to be able to pull out relevant information for a whole host of reasons. They can look at longitudinal data and determine the quality of the care provided, and that includes whether care was appropriate or not. And there's so much that AI, as they know, can be used to help determine whether or not care was appropriate, whether or not the volume of care was appropriate. So this, as therapists, I hear a lot of, we've talked about this before, but I hear a lot of conversation in the therapy community, at least on LinkedIn, about, using RTM, maybe not as carefully or as with as much discretion as they perhaps should, or at least consider. And one thing to keep in mind, as data is exponentially improving, the ability to analyze that data is improving, the access to data is improving, being able to look at how utilization leads to long-term longitudinal outcomes for patients is easier and easier and easier to detect. And that's the goal, right? So if, giving a practical example, if you're going to be using RTM and billing it on a monthly basis, it is already, but as the data becomes more available because of directives to make it more available and companies having to comply with that, it is easier to say this RTM code being used on this type of population in married with a certain volume of in-person and or telehealth visits, that combination together does or does not lead to both better outcomes and lower cost. So so think of it this way, if you're just adding RTM and you're not thinking about how that allows you to, for example, wean a patient off, or be much more specific about how often you have to actually interact with them person to person on telehealth or in person, acknowledging that that's very important still and for therapy and will continue to be. It's the way our profession is. But I encourage therapists, knowing and hearing what I pay a lot of attention to just be very cognizant that how you're using these technologies and how you're billing for them, the benefit to CMS and to those who created these codes, the benefit is that it should reduce total downstream spend because it is allowing more engagement when people need those touch points. So not every patient's going to be, lower billing, but that overall spend should be improved upon because we have such trouble engaging with patients normally that when you add that additional engagement through RTM, it should naturally improve your outcomes and potentially should reduce total cost of care down the line, right? So patients are more engaged. They don't need to access that really high cost care that's related to the kind of care we deliver.
No, I mean that's perfect. I think like trying to have an entire itinerary of what you just mentioned. That was a terrific voluminous and well-structured data transference of information. But the first thing to discuss is the EMR data, right? And the collection of EMR data specific to the quality and the purpose that it will serve. I just had this discussion yesterday with a group of therapists, and a simple thought experiment is, when was the last time you went back a week to reference your notes from a week ago? And that could be a very useful instrument, a very useful thought experiment to the quality of notes you take. Now, so there is a saying, right, in data analytics, which is like poop in, poop out, right? Like if you're only dumping really non-granular and non-qualitative data into EMR systems, anything you can extract from it is going to be equally as poorly structured. And unfortunately, that is what you're seeing with a lot of EMR data extraction, both based on ICD-10 codes, which are inaccurately being populated. ICD-10 codes are being populated based on the likelihood of reimbursement, not based on a defined clinical condition, partially due to poor understanding of how to apply ICD-10 codes, and partially due to these friction points, which contribute to denials of payment when an inappropriate combination of ICD-10 codes is used, or an ICD-10 code that is not covered for the specific condition is used. So then most individuals fall to the lowest common denominator, which they know that there's going to be codes that are reimbursable, and those are the codes that are going to be used indiscriminately regardless of the clinical condition. So when someone is trying to create a more empirical analyses of clinical recovery, and they're doing it based on diagnosis codes, the data they're pulling out is immensely inaccurate, at least in the physical therapy world. And I know the transition from ICD-9 to ICD-10 to, in the future, to ICD-11 to become more and more precise about clinical diagnostics and clinical conditioning. It's well thought and poorly executed. So that's one. The data in terms of clinical encounter itself is also poorly structured. So you do see a proliferation now and emergence of these advanced EMR systems that use voice recognition and use scribe features, which I think is a absolutely right step because it liberates a human from data entry, which is a redundant, low-value task, into a more of a conversational style data and capture, which is what it should be. So then the scribe features will capture the entire conversation between two humans, and then you can create a defined rules based on specific tags or specific words or specific sentences that will then store this data. So hopefully in the future that will create a little bit more granular EMR based data. But then the entire episode of care, I think, really the true value of that EMR data is going to be lost based on the purpose that the EMR data is serving, which is to create a compliance and eligibility for reimbursement, not to actually document a human suffering or a human clinical condition and the response to interventions that you have applied. So that's one. That the second part, that the model of care, right? Like, we can again discuss that two separate models, or why don't we discuss three separate models? The first one is the digital first strategy, which is using systems like RTM to create an asynchronous environment and early access for individuals in need of care. So these RTM or remote-based systems create asynchronous ecosystem for a human to onboard. And then that once they're onboarded into a digital system, a stratification process occurs, and then a person is being directed or triaged into the right resource that's available. Be your digital first. Then we can talk about the team-based approach, which is more of a mixed hybrid, where an individual has a choice of where to enter the system. They can enter a system with one of the medical providers, like a therapist or a physician or a advanced trained clinician. And then from that system, they are then being triaged into an appropriate, where it is the human or the clinician that makes a decision that you are more fit for a digital service, you're more fit for an in-person service, or a combination of both. And I think that model can serve well too, as long as everybody's on the same page, right? So that's where we, as I think, a clinical community, and especially like maybe even you and I being the voices of reason, can create a call to action where, like, train, if you have an organization with more than one satellite, create already pathways for that stratification process to occur, create a conversation points, and create almost a script for the proper level of fitness for a individual in need of care, whether they need to be receiving care through the digital, in person, or a combination of both systems. So that's my spiel, Dana. But I think that EMR data itself, I'm still conflicted about the true value that it serves, besides the ability for the academics to publish, and that true digital first ecosystem, when operationalized, can be a true game changer. Except nobody's figured that out yet, right? Like, there's still a process, right? We're still in an eternal beta mode.
So perfect launch to make the point from what you just said as a reminder that CMS and the Innovation Center, who are now, as they say, functioning like this, Chris Klump at the Center for Medicare and Abe Sutton at CMMI, and they can do and require what they want for participation in models, and then mandating that participation in a model means that you either get on the ship or you fall overboard. So, right, assume the Innovation Center, as they say, they're going to have mandatory, some level of mandatory models and participation required. I'm going to break it down two ways to how they pull in participants, right? They can mandate certain health plans participate in a model. They can mandate certain providers participate in a model. That could be through geographic region. That could be through a randomization. That could be a whole lot of different ways. But then, really interestingly, they can mandate participation in a geographic region, but to the beneficiaries themselves. And there's a great example of this geographic direct contracting model, which was put out at the end of Trump 1. Biden administration removed it before it started. There's, a lot of interest in that model again. What that model looks like, and I'll tell you specifically why it's so relevant to this. What the model looks like is we as CMMI would be saying, okay, we are going to have all of the beneficiaries in fee-for-service, for example, living in any of these particular geographic regions in the country, metropolitan areas. They could do CBSAs, they could do a whole lot of things. An example last time was Philadelphia was one of the regions that they were going to roll this model out. They could just say, okay, we're going to give contracts to a couple of organizations who apply, and then we are going to randomize all of the Medicare beneficiaries in that region and assign them to one of these organizations. And these organizations would have to make a bid to CMS, just like a Medicare Advantage plan does. and say, we are willing to care for this population of fee-for-service beneficiaries for X amount. They get the bid, they're given the dollars, like an MA plan is given the dollars. And then that organization, that entity, has to then go out and contract with, they're going to use data to do this, to contract with the highest value providers of every kind possible in that area. That would be the goal, right? So that includes therapists. So if you have this entity in, let's say it's Philadelphia again, and you're a therapy practice practicing in that area, right? Any organization that's already like an MSSP, a shared savings program in that area, they're going to have to contract with that entity. If you're a physical therapist or a therapy provider group and you're living in that region, well, you don't have to contract with that entity, but if you don't, certainly know that others in the area are going to, and they will be, in all likelihood, asked to participate or given some kind of a review to determine if they even want to work with them, right? And so some of these things to keep in mind, there's a whole lot of flexibility that these like a Center for Medicare and Medicaid Innovation has. And this administration is very different from the last 4 years, meaning they want to see progress and they want to see savings. And until you take providers and put them into a situation where now we're going to pay you differently. We're going to reward you for doing a great job and helping us all across the year care for patients better, keep them home, keep them out of the hospital, right? If you're if you're not aware and not willing to do that or don't know to participate, you're going to be left behind those that are aware and are proactively thinking about how to be successful. And just last thing, because I want to relate it back to what you were talking about with ICD-10s and the future 11s and data, they could make requirements, the Innovation Center, that EMR data contains certain elements, number one. Number two, they don't have to stick with determining diagnoses based on ICD-10s or ICD-11s if we get to that point. I mean, they were so far behind getting from 9 to 10, where they're using 10 for benchmarking purposes, which only just happened 2 years ago. They could, this could look a lot of different ways, but they could just, as Abe Sutton has written about, and I encourage everybody to look at this article that he wrote last year in Health Affairs on an inferred risk model, using all longitudinal data, everything in claims, historical data, using data they get out of EMRs. They can determine what they think is the risk level of a population and specifically of a person. And then they can relate the spending and the downstream spending that was prevented to the provider and to that individual patient. So just because we use diagnoses made by providers now doesn't mean that AI doesn't allow those making the rules to change what data is going to be used for what inputs. And requiring APIs between providers, EMRs, requiring certain types of documentation, requiring the use of scribes, all of these things are potentials for an innovation center to do. And I know that more physicians generally are going to be aware of this before therapists. And so what we're trying to do for the therapy community as part of our podcast is future-proof you, right? Encourage you to really pay attention to what's going on because it will affect you, but it's a matter of when and how. Will it affect you so that you take advantage of good incentives and can get into the risk game? The risk game can be great if you're prepared. If you're willing to bet your ability to get better outcomes on your care, more of the dollars can go to you because you will provide the appropriate care. Appropriate care meaning this is the right care for this patient, and we're going to avoid other variable, potentially unnecessary care because we provided appropriate care. Therapists provide and need to provide so much more to more of the population, appropriate care versus higher interventional care. All those things with the right data inputs can be figured out by those analyzing that data that care a lot about using dollars better.
Yeah,
So,
I think you can summarize that in a simple terms of we need to keep it simple, right?
yeah, for sure.
And I think if we're gonna see a higher level integration of this, we really need to create a structure of these models that are incredibly simple to understand and simple to apply. Any other way, so like you and I may dig deeper into understanding of how these models will reimburse for these advanced management strategies. But really, anyone who is trying to just survive, right, like on a clinical level, is going to be inundated with their daily minutia that they're just going to throw their hands up in the air and say, "Forget it, I'm just going to go cash only," right?
Uh-huh.
So because it's easier, right? It seems like an escapist, like it's just not worth my time and energy when cash is what I understand. So I'm just gonna go out of network and stop accepting any federal or private payer because it's too much work. So the study you're actually referencing right now, it's a wonderful study, and Tim Marshall is a great dude from like he's with Ivy Rehab. He's really trying to apply data on a large structured organizational level. And then Mark Groner is a wonderful dude also at Limber, who has really been making his strides and making indent into uh, using this really valuable and value oriented remote model and data oriented model and apply it to musculoskeletal care. So we can discuss this
Yeah.
case control study to really as a sample of well structured hybrid organization and well structured application of RTM systems, and potentially use this in our notes for this episode as a case sample for any other organization or any other provider to create a model for themselves that they can imitate and emulate for the future. So
So before we start talking about it, for those who are just listening to this on a podcast app and you don't see our screen on YouTube, this is called a retrospective case control study of the effect of in-person physical therapy with remote therapeutic monitoring on functional status and adherence, which is that word adherence is important, among patients with musculoskeletal conditions. It was only published on May 24th of 2025. This is the journal Pre-Proof. And Mark Gruner, he shared this with me. That's why I'm aware of it. I didn't just happen to come upon it on my own. I think what's important as we take a look at this study that we, both just saw is, as Alex mentioned, one of the things that has to be figured out is the right dose of in-person versus remote care, and what amount of each is going to lead to the best outcomes. And crucially for payers, what they care about is at the best cost. Now, they're not just thinking about the cost of the care that you're providing, the care that you're providing, I and probably Alex too would argue is well undervalued. That if you're avoiding really high cost care, orthopedic surgery, imaging, injections, etc. That high cost care avoidance is one of the areas where we need to be shouting from the rooftops that we are underutilized at a population level, that our value is not being extracted nearly as it should be, and that we are not being reimbursed the way we should be for the amount of care we're avoiding. This is what advanced primary care practice is at risk, how they're making, if they're successful, substantially more income for the practice is because they are being valued at a higher level, being reimbursed differently, and are winning financially when their patients are healthier, right? We have the same capability for a range of musculoskeletal and movement-based conditions. And so when we look at something like this is going to look specifically at, right? We had in-person PT, we had RTM. The TLDR is patients did better when they had the combination. We'll take a look in a little bit more detail. But that is step one for proving the value of this hybrid component. And it looks like we'll also link the Peterson study that they did, although spending may have been higher in this combination than sometimes remote only. I don't think that's hard to imagine why. We can't get stuck there. What we need to be shouting from the rooftops, I think about here is, yeah, maybe spending's a little higher when we combine the two. We still need to be very careful about the dosing so it's the most appropriate and everyone's being seen at the right cadence individually. But the true value to those who have to reimburse for this care is the care that we're avoiding, right? like what we just talked about. A lot of it has to do with orthopedics, but it's also falls and surgeries and accidents and balance issues, all of those things that cost the system a lot of money. We have to claim the value of our work in preventing that. Because as I've said before, not going to go down a tangent, but what payers who are paying for care really care about, just imagine, right? They don't care about every individual thing. They care about for each person that they're insuring, whether it's CMS is insuring them or an MA plan or whatever, they care about the totality of spend over 12 months. And what are the big rocks? Hospitals, inpatient rehab, SNF, imaging, specialty care also falls in that bucket, right? We're not that. We don't fall in that bucket. We're high value. So time to own that. I'm going to pitch it back to you as I scroll a little bit here, Alex.
No, right on, right on. So I think the spend, the predictable spend versus the factual spend, right? And if you look into the economic levers and downstream effects, we are just disgustingly undervalued and disgustingly underutilized. Considering that we in the United States, you have 270,000 well-equipped, well-structured, and well-educated professionals really capable to take on the slack and the vacancy in coverage and access of care that is present due to the shortage of valuable primary care services. At the same time, if you look at the, like, if you build it, they will come phenomenon. When you create systems that can be abused, systems will be abused. And when you create systems that are without properly defining the proper operational cycle, these systems are going to be plugged indiscriminately and most likely to make up for the gap in reimbursement from other channels. So if you look into the statistics of RTM utilization, just financial utilization, in 2023, RTM market was valued at $380 million, and in 2025, the projection is to be valued at $1 billion, according to the Grandview research. So that's a three-time multiplier in 2 years, which is really, how would you explain that? Like these systems, there's no new systems on a market per se. There's no high level of adoption, and yet the valuation goes higher. Is it because the systems are getting better or being accepted more, or is it the fact that we're just learning how to apply these systems for for better reimbursement? We're learning to finally play with them to make them available to us. There's definitely opportunities to create a viable structure, but I do think that to be on a little bit of a devil's side, there's also a risk of these systems falling into a trap of being another modality that can be used to or plugged in to enhance reimbursement without actually adding or creating value to the patient and without adding any value or improving clinical outcomes. So,
Uh, so I wasn't planning on bringing this up, but it fits, I think. And again, we're trying to future-proof this profession by bringing to you trends and maybe things that in the news that you're not paying attention to because you're entrenched in your day-to-day caregiving and other responsibilities. There's a tool being used to look at the spend that we would attribute to a specific provider, we call it, globally episode groupers. And I am not an expert in episode groupers, but I would encourage you, if you're interested in understanding what this is, because it's so very applicable to physical therapist, occupational therapy, musculoskeletal care. As one of the things that makes it challenging to figure out how to reduce specialist cost at the specialist level, not at the upstream level, but at the specialist level, is to be able to create an irrefutable argument that certain spend that ends up happening is or is not attributable to a certain provider or providers. When we can be very clear and specific and accurate about what spend should or should not be attributed to the care of a certain provider and their group, we can get really specific about calling out quality in a different way. If we establish best practice standards and we can look at the difference between different providers using this episode grouper methodology, pulling out very specific components of episodic care. Episodes can be yearly, they could be monthly, they could be 6 months, right? If we look at how that spend is broken down in a really clinically meaningful and data-driven way, episode groupers are a powerful potential tool to develop alternative payment structures and to either penalize or reward different providers providing appropriate and evidence-based practice to the best of their ability. So the episode grouper, a really common one used is called the PACES model. Another one, and that's probably the one I'm hearing about the most being used, is the PACES model. There's another one called Prometheus. I haven't heard that name being used as much lately. But and there are I hear about another one that's in development by another actuarial firm. So, I tend to just think about what noise do I hear, what's starting to bubble up, and typically it's a signal of something coming or something that's bringing, there's more attention being brought to it. So I just encourage everybody to take a look at those, what an episode grouper is, and just do a little bit of desktop research. And, we'd love to always hear from any of our listeners about what you think about this, and happy to dive into it more. But I think episode groupers, if a grouper can attribute good and bad spend to a provider, a group of providers, it can then be used and you can look at that information in combination with using digital tools and figure out where you are getting more or less value for interventions you're providing. And that matters a lot in a realm where spend just doesn't stop going up. And we need to figure out a way to get control of it. And now we also have leadership at the biggest payer in our nation and the Innovation Center who want to really attack this head on and use every bit of available and better data to determine how we should be rewarding, punishing, structuring, incentivizing providers and beneficiaries even.
Yeah, I think that's very very well articulated, Dana. I think let's call things for what they are in regards to the spend, right? Like and like we can be very open and transparent about what costs the biggest spend and what's the biggest burden for these services, and we're not it. Like so if you look into the procedural spend, if you look into the diagnostic imaging spend, and then if you look into the fractional spend of us and our discipline, this is where the collaboration between different disciplines and organizational discipline is relevant and pertinent, where in order to control spend, we really have to potentially revisit our prior topic of the path dependence, that onboarding of the individual in need of care, and how access and accessibility to these services, and then creating a
Yes.
cultural shift, right, from access in a traditional method through the path dependent medical system, which creates a much higher spend, to a almost a nudge or a choice architecture where that path dependence starts with the musculoskeletal professionals or allied health professionals who then using technology can better triage services, triage care, including some of the newly present capacity to refer for diagnostics, to refer for further downstream of services if there needs be, right? But the overall, I think in order to control spend, you really just have to create a almost a nudge to increase onboarding into the specific discipline as a first point of contact, first point of care, which we can definitely reference back prior episodes, right? But it's I think to summarize everything we have spoken right now, there is movement. I think I'm very happy to see that on a federal level, that there is an effort to create structure and to create models that will better control both data collection as well as data utilization for better clinical outcomes and for better accessibility to clinical services. Now, the question is the uptake, the duration of uptake. Would it take another 3 years where there's going to be potentially a change? And then would that change any efforts that was put into play prior is going to be taken off and written off, right? And the second part, I think, in the summary is on a macro level, all these things are happening, but how do we translate this to the micro level, to the trenches where clinicians can actually take this information and make it actionable, which we've already seen, I think, in our episodes of discussing how a clinician, Cody, was able to use information to actually create change on a local level. But what are the tools that clinicians can take? What are the resources they can reference to actually just take it and apply it today, tomorrow, a day after tomorrow, so that this change starts to take shape on a local level, on a micro level? I think that is the foundation of this future-proof PT, and the true, hopefully, foundation of where some of these resources can be better used in the future.
I am going to make, yeah, it was a great wrap point for you. I'm going to make a couple myself. First, on the state advocacy side, which I'm glad you brought that up. And our little short that we published on YouTube of Cody describing his advocacy went viral in terms of what our recordings are doing. It got, the last time I looked, it was over 1,000 views. To us, that's practically viral. But as just a kind of food for thought for any of you doing all of that really hard on the ground work in the States, to really think about positioning for appropriate care, that access to our services helps when it's at the state level. It helps states to meet more of patients' needs. It improves access to primary care delivery, keeping in mind 30 to 40% of primary care visits are because of musculoskeletal, right, and movement disorders, and the cost of that per year. When it comes to something like imaging, which I'm just blown away by the progress that the state therapy associations have made. We are high value providers at deciding who is right and appropriate for receiving imaging. And we don't require then, based upon that imaging, where we can get the independent ability to prescribe that, we then can avoid high cost ortho care when it's confirmatory that there's no particular need for a physician specialist to see a patient. It is our ability to provide appropriate and high value care that has to be leveraged, and there's so much room for improvement. Again, to reiterate too, we should be accessing a far larger percentage of the population than we are. However, as we start to do that, and I predict that it's unavoidable as long as therapists can get on board, that we need to be accessing many, many, many more patients that we never touch, but need to be cautious about dosing properly. What does each patient really truly need? If you can imagine, if we start to see 10 times more of the population, the patients we never see because they get referred, they never come to therapy, they can't pay the copays, they won't pay for transportation or have no way to get there, they've not had a great experience in the past, and so they decide it's too burdensome, whatever. If we have direct truly access to patients when they need our care, and many more of the population, we're going to have to be much more careful about how we dose, because we're going to be needed for so many more patients, right? We're going to need a much higher volume of touch points. So to keep that in mind, careful about each patient, how much we're utilizing, because we're going to need to be utilized at a much higher population level. And then the last thing I wanted to point out for everybody is to take a look at, we'll put it in the show notes too. After Abe Sutton delivered his strategy a couple of weeks ago, the next day he showed up and interviewed with Mark McClellan, who leads the Duke Margolis Health Policy Center, had an interview with first Dr. Oz, who introduced Abe Sutton. And as Abe Sutton described, I jumped out of my seat with excitement watching this, that he was describing that an example of high value appropriate care is more patients getting physical therapy and not needing orthopedics. We'll put it in the show notes. Take a listen to that. These are signals. If the director of the Innovation Center is saying and notices something like this, if organizations that provide physical therapy, provide tech for physical therapy, if they're getting noticed, for example, by venture capital firms or larger organizations are looking to get into the therapy space, these are the signals we should all be paying attention to and try our best to read the tea leaves so we're prepared. It's the innovators that are going to win. What we're talking about is not a maybe. It's going to happen. It's just a matter of the timing and who's going to be prepared and who's going to benefit from it. So therapists, be part of who benefits from all of this change that's happening. It's real. It's here. Looking at the signals. I know we have to wrap.
Oh,
This
awesome.
has been,
I'm so happy that we have an opportunity to have a voice out there. And it's so excited that we're going viral with over 1,000 clicks. Thank you, Cody. And thank you
isn't
for
that
this.
cool?
That's pretty awesome. I think again, having conversations, being amongst our people, and actually having these in the last couple of weeks, being around our clinical community. There's just so much positive change that is already occurring, and hopefully there's going to be that more of a voltage effect that is just going to be something that takes up, and there's going to be this higher, almost evolutionary change for our profession, where we take ownership and responsibility of the better things to come for our profession. So thank you, Dana. This has been great indeed.
Yes, thank you, Alex. And please, everybody, if you enjoyed this, share it with a friend, subscribe, and it would be so terrific if you could write us a quick review, give us 5 stars. We got our first review I saw on Apple Podcasts, 5-star review. So we would love to see more of them. We so appreciate you listening to us. We're growing and learning every time we record one of these. So again, thanks, and we will see you soon.